Welcome, everyone, to the Society for Skeletal Radiology Resident Education Club webinar. I want to thank Patrick, Cheryl, Mike from Veritas, as well as the SSR leadership for the resident education for making this possible. My name is Ji Win. I'm a pediatric MSK radiologist at the Children's Hospital of Philadelphia. I will be serving as the moderator for this session. This will be our last webinar for this academic year, and we'll resume in the fall of 2025-2026 academic year. And for this grand finale, it is my pleasure to introduce Eric Tung. He is currently a pediatric radiology fellow at the Boston Children's Hospital. He completed his diagnostic radiology residency training at the Massachusetts General Hospital, where he spent 12 months of focused training with the Division of Musculoskeletal Imaging and Intervention. Eric's passion is in medical education with clinical interest in pediatric and musculoskeletal imaging. So without further ado, welcome, Eric.
Thanks, Dr. Wynn. Thanks for the introduction. It's a pleasure to be here, and thank you to the SSR for the invitation. So welcome, everyone. It's great to be able to speak to you at this last session. The topic for today is a really important one in pediatric musculoskeletal imaging, and we'll be talking about osteoid osteomas. But not just osteoid osteomas, some other lesions that are really important to keep in the differential and that can create a lot of inflammation, like osteoid osteomas. I think like a number of the other resident education clubs will be using poll everywhere. I'll just take a moment to kind of keep this up on the screen, but please feel free to join. And the format for this lecture will be kind of a case conference format where I'll show an unknown case, show a multiple choice question, we'll answer it, and then we'll kind of discuss the case and work through the lecture and the learning objectives. And so I don't have any financial disclosures. And what I hope is that by the end of this lecture, that you will be able to really feel comfortable describing the typical features of an osteoid osteoma, to be able to recognize some of the atypical presentations of osteoid osteomas, and to be able to provide a differential diagnosis for an inflammatory lesion in a child. And so recognizing that inflammation can really help you narrow your differential. So let's start off with a case here. This is an 18-year-old male with several months of knee pain. Now, I promise not all of these cases, the answer is just going to be osteoid osteoma, but I'll leave it up for a short while. Take a look at the images, and then I'll show you our question. So this 18-year-old has had several months of knee pain. The question is, what's the best next step in this patient's care and trying to understand what's going on? Good, and I'll pause it here. So it looks like that we have a mixture of people saying for follow-up CT scan and reassurance with conservative therapy. And when we look at this case, and going back to this, what we can see is we've got a frontal radiograph, or this looks more like a tunnel view of the knee here. And there's really not much to see here. It's maybe some vague sclerosis if you've got those eagle eyes. But when we look at our kind of a sagittal T2 fat saturated and axial T2 fat saturated image, we see that there is a lot of marrow edema of the proximal tibia. And we know that while this is pediatric radiology, that this is an 18-year-old male, their physes are fused. This patient is skeletally mature. And so we can see kind of our physeal scar here, but we see that there's a lot of marrow edema within this proximal tibia, some of it extending into the popliteus muscle as well. And if we kind of look where this marrow edema is centered, we see that the PCL is kind of attaching here at its footprint, but we also see that there's an area of the cortex that almost seems to be centered within the region of bone marrow edema-like signal, as well as the muscle edema-like signal. And so especially in younger children or in kids, we should be thinking about with cortically based inflammatory lesions about osteoid osteomas. And one of the best ways to really evaluate and to confirm this diagnosis by imaging is to get a follow-up CT scan. And so once again, we saw all of this inflammation, and we saw that there was this cortically based lesion. And when we get our CT scan, I think a lot of you are much more familiar with some of the findings that we're seeing, which is that we have this lucent lesion that's kind of centered on the posterior aspect of the cortex. There's a little bit of internal mineralization, and there's a lot of periosteal new bone formation surrounding it. And so I think it's sometimes quite humbling to kind of get these follow-up CTs and say, oh, that was a classic osteoid osteoma, but it can be challenging to kind of pick this up on an MRI, which is often what we go to in children who are having pain and initially have what look like negative radiographs. And so this was an osteoid osteoma. And of course, this is the topic of our talk. So osteoid osteomas are benign osteoid-rich tumors that incite strong inflammatory responses. And this is from a release of prostaglandins that really incite a lot of inflammation in both bone and soft tissues and any surrounding structures. They typically occur in younger patients, which is why, as a future pediatric musculoskeletal radiologist, this is a topic I'm very interested in. And, the most common kind of age that we see these patients is in the second decade of life, as well as, even extending into the third decade of life. However, when we looked at our patients that had been at Mass General Hospital, we had patients that had osteoid osteomas in their first year of life. They were in their only a few months old. And we even had a patient that was in their 50s that had an osteoid osteoma. And so this isn't a strict age kind of criteria here, but something to keep in mind that typically occurs in younger patients. For some reason, which we don't really know, there is a strong male predominance to osteoid osteomas. About 75% of cases are in males. And the classic presentation you're probably familiar with from training, which is often, they'll give you nighttime pain that's relieved by non-steroidal medications and anti-inflammatories. But really, you should be thinking about osteoid osteomas in any patient that has kind of subacute or chronic pain, doesn't really have, a clear inciting event that even if it doesn't happen during the nighttime or you don't have this history of relieved with NSAIDs. And keep in mind that, osteoid osteomas most often occur in the lower extremities in the long bones, including the femur and the tibia. And so in our looking back at those cases at Mass General, which are over 700 cases, 75% of them were in the femur and tibia. And so when we think about some of the typical osteoid osteoma imaging features, these are kind of the things that I think should come to mind on both CT and radiography and MRs. And so, the classic lesion is going to be this radiolucent tumor. Historically, it's been described as having to be less than 2 centimeters in kind of diameter, and it may have internal mineralization within it. Now, you'll hear the phrase nidus thrown around a lot, and a lot of people describe these as niduses. I had one of my attendings that I worked with who was very passionate about not using the term nidus because it can become a little bit confusing. Really, what we're looking at is a tumor with internal mineralization. And some people don't know if the nidus is referring to the mineralization or it's referring to the radiolucent part, but really this is just the tumor with mineralization. But keep in mind that a lot of people will call these niduses. Most often, these are going to be diaphyseal or metadiaphyseal and extra-articular. They are often cortically based, and we'll talk a little bit about some of the possible locations, but usually they are eccentric within the bone and close to the cortex or in the region of the cortex. And a very classic finding is to see surrounding periosteal new bone formation or periosteal reaction that will have a non-aggressive appearance, a smooth appearance, but can be quite robust and can even extend into adjacent bones that are nearby, especially in things like the pelvis. And one of the most classic features that we're going to be talking about a lot is that there's a lot of surrounding marrow and soft tissue edema. Now, when we treat these, the gold standard non-operative treatment is radiofrequency ablation. And so these are kind of the steps that we'll go through typically for a CT-guided radiofrequency ablation. You start with a preliminary scan where you identify the lesion. You will then administer local anesthesia, at the skin surface, as well as extending down to the bone surface. You'll advance your introducer to the periosteum and then provide a lot of additional anesthesia at that periosteum because that can be quite painful in patients, even under conscious sedation. And then the bone drill is advanced until it's within 1 millimeter of the nidus. A single core biopsy is usually taken, or at least is often taken coinciding or occurring before the ablation. And this when you enter into the actual tumor itself, you because it can release a lot of prostaglandins, you may see that the patient's heart rate may rise, or they may notice that some of the other kind of vital signs may change as a result of getting in. And that's actually a good sign because it tells you you're probably in the right place. Then a coaxial radiofrequency ablation electrode is advanced into the lesion. And then the common kind of pattern for heating and timing for that radiofrequency ablation is to heat the tip of the probe to 90 degrees centigrade and to keep that for 6 minutes to create about approximately 1 centimeter sphere of ablation. And there may be additional ablation treatments that are needed, especially for larger lesions. And so understanding and having good imaging to understand the size of the lesion is really important. Now, when we talk about these classic imaging features of osteoid osteomas, I want you to understand that radiology is humbling. Sometimes we see a case that looks like it's a perfect case of something, and it turns out to be something else. And so these were all cases at Mass General of lesions that were mimicking, could be, were considered to likely be an osteoid osteoma, but turned out to be something else. These were chondroblastomas. You can see that these were all epiphyseal lesions. These lesions here were chondromas. The red lesions down here were non-ossifying fibromas. These were enchondromas. And then this was Brody's abscess. And so it's important to keep in mind that you may want to use the term is most consistent with an osteoid osteoma, or is a presumed osteoid osteoma, because sometimes we don't know until we put a needle in it. And so from some work that I did over at Mass General, we looked at over 600 cases of presumed osteoid osteomas that underwent biopsy and ablation. Only 2.3 of them, 2.3% were actually mimicking lesions. These were some of the lesions, but there was actually one case of an unspecified carcinoma. It was in a 30-year-old gentleman over decades ago, but was quite surprising. So I advocate for those that will be doing ablation of these to take a small sample right beforehand. It's pretty quick and really can help identify some of these mimicking lesions. So the take-home point for case one is to really understand these typical osteoid osteoma imaging features, keeping in mind it's not diagnostic until we put a needle in, but some of these would be a radiolucent tumor that's less than 2 centimeters that may have internal mineralization. It should be cortically based in the diaphysis or metadiaphysis, often has surrounding periosteal new bone formation, which can be difficult to see on MRI and really has this prominent surrounding marrow and soft tissue edema. Let's take a look at this next case. This is a 3-year-old with leg pain. I'll keep the images for a moment, and then we'll go to the question. So what's the most likely diagnosis for this lesion in this 3-year-old? We'll keep the poll up for a few more seconds here. So we've got a nice differential here, and we have the majority of people saying osteoblastoma, with the second most common being Langerhans cell histiocytosis. When we take a look at these images, we see that we've got a frontal radiograph of the femur. We see that there's smooth periosteal reaction that's kind of present along the shaft. And we see that there's kind of a vague lucency, which is very hard to tell prospectively, but then will correspond to the lesion that we're seeing. And on our coronal T1 weighted imaging, we see that there's this elongated lesion. It tends to be more central within the diaphysis or intramedullary lesion. It has a lot of periosteal bone formation and a lot of soft tissue edema surrounding it. And so this was a case of Langerhans cell histiocytosis. And this can be very challenging, to make these diagnoses prospectively, but this kind of location and appearance of this central lesion with a lot of inflammatory surrounding inflammation, especially in the femoral shaft, is kind of a classic look for LCH. And so LCH, or Langerhans cell histiocytosis, is a neoplasm arising from expansion of early myeloid cells known as Langerhans cells. And these Langerhans cells are dendritic or antigen-presenting cells. They have these defining feature of Bierbeck granules, which are these organelles that are specific to Langerhans cells. And it's often a diagnosis of children, and typically seen in kind of toddlers or in young school-age children with a median age of 3 years. And really, these infiltrations of Langerhans cells can affect a single organ or multiple organs. We think about them a lot in the bones, but they can occur in the skin. They can occur in solid organs. I had a case earlier this year that was quite confusing, but presented with a lot of lymphadenopathy, and that ended up being Langerhans cell histiocytosis. But of course, we're at the SSR, and we're going to focus on the bony presentations of LCH. And so when we think about some of the typical LCH skeletal imaging features, When we see these lesions in long bones, they're often diaphyseal and intramedullary, and they have robust periosteal reaction and prominent surrounding marrow and soft tissue edema. And so this is why this is on the differential for an inflammatory lesion or something like an osteoid osteoma. Keep in mind, this is not a great look for an osteoid osteoma, given its elongation. Osteoblastoma is another thought, and certainly on the differential, and is a good thought and something to think about. Keep in mind that there are other places that these LCH lesions tend to occur. For instance, in the skull, they can present as lytic lesions that can really erode the cortex and result in these kind of what is described as beveled edges, which is the way that they erode the inner and outer tables kind of creates these edges. And when they occur in the spine, a classic manifestation is vertebra plana, which is really kind of representing a severe insufficiency fracture from this infiltration of these Langerhans cells. And so really the key take-home point for this is that we're starting to build, and we will continue to build through this lecture, differential diagnosis to consider in kids with bone lesions with prominent inflammation. So in addition to osteoid osteomas, we should think about Langerhans cell histiocytosis. Let's take a look at this next case. This is a 10-year-old male with several weeks of progressive atraumatic hip pain. The question is, what's the most likely diagnosis? Osteoid osteoma, osteomyelitis, stress injury, or juvenile idiopathic arthritis. And I'll go to our poll here. Give it about 10 more seconds. So we're pretty split here between osteomyelitis and JIA. And so when we look at these images here, we see that there's a lot of marrow edema that's kind of present within the acetabulum. We can see that there's a asymmetric effusion or perhaps synovitis that's present in this right hip. And in our CT, when we kind of look in this region of this edema-like signal, we maybe see a little bit of lucency here, but not really seeing too much, not seeing a lot of periosteal new bone formation or anything like that. Now, what would be the optimal way to localize this tumor prior to ablation? I apologize, I'm skipping ahead a little bit, but really what this represented was actually an osteoid osteoma that was located right here, kind of centered in this region and represented this lucency here. And so, but it can be very challenging, in prospectively to identify that osteoid osteoma, especially when they're intra-articular in location. But if we were trying to best optimize or pick the optimal way to localize this tumor prior to ablation, what would be the best way of doing this? Would it be a sodium fluoride scan? Would it be a repeat CT in 1 month, a repeat MR in 1 month, or arthroscopy? We'll pause here and we see that the most common answers here are the sodium fluoride as well as the repeat CT. And so as I was describing, we see that there's a lot of marrow edema and the synovitis. We see that there is this lesion right here, but it can be quite hard to see prospectively. And this was, as I mentioned, an intra-articular osteoid osteoma. But one technique that can be very helpful to identify where the nidus is or where the tumor is to use some nuclear medicine scans, things like a bone scan, or in this case, a sodium fluoride PET. And so what we can see here is that there was intense uptake of the radiotracer at the site of the tumor, which can really help localize it and assist, either our musculoskeletal radiologists or interventional radiologists in the ablation that they will do, because it's, or radiofrequency ablation is only creating a 1 centimeter sphere, and we really need to get into the right place. And so once again, this is the sodium fluoride PET, and we can see that it's really highly localizing where the tumor is, which is right at this location here. And so this is one of the first atypical osteoid osteomas that I want to talk about, which is when it has an intra-articular location. And so when we think about extra-articular versus intra-articular osteoid osteomas, only 10% of them are actually intra-articular. And, by nature of being intra-articular, while the majority of extra-articular are going to be diaphyseal or metadiaphyseal, the intra-articular ones will typically be epiphyseal or metaphyseal. Now, we talked about kind of the typical presentation for extra-articular osteoid osteomas, which is nighttime pain that's responding to NSAIDs. But intra-articular osteoid osteomas can present a little bit differently. It can be this non-specific subacute pain. Sometimes it's just limited joint range of motion and can really elicit some other diagnoses, including juvenile juvenile idiopathic arthritis and other inflammatory arthropathies. Keep in mind that the onset to the actual diagnosis of osteoid osteoma is much more delayed with intra-articular osteoid osteomas because of this kind of atypical presentation. And then the rate of misdiagnosis is higher as well, because it's really not following these classic rules that we think about with typical osteoid osteomas. So here are some of the typical intra-articular osteoid osteoma imaging features. We see that there is, once again, a cortically based lucent lesion with internal mineralization. We see that there's prominent surrounding marrow and soft tissue edema-like signal. But keeping in mind that you're also going to have inflammation of the surrounding joint, creating synovitis and joint effusion. And we often don't see a lot of periosteal reaction with these intra-articular osteoid osteomas. Now, as a side, and related to our second question, nuclear medicine can play a very important and complementary role in our diagnosis of osteoid osteomas. These sodium fluoride PET CTs can create really beautiful imaging with high resolution to kind of identify the location of these tumors to really help confirm a diagnosis and also to help with treatment planning. But sometimes we can use nuclear medicine to help confirm that we've removed a tumor. This was this case where we had an intra-articular osteoid osteoma at the talar neck, and that we could see that imaging was done from a bone scan before surgery. This was actually surgically removed. And then after surgery, we can see that there has been resolution of that focal uptake, confirming that the tumor had been removed. So the take-home point here is that intra-articular osteoid osteomas differ from extra-articular osteoid osteomas. They're less common. They may present with more non-specific symptoms. They're less likely to have periosteal reaction, may just present with this joint effusion and synovitis, and really are harder to diagnose. So you should keep this in mind. And then as we work through a few more cases, we want to be aware of these atypical presentation of osteoid osteomas, including intra-articular location. Let's take a look at this case. This is case 4, a 13-year-old male with several months of knee pain. What's the most likely diagnosis for this lesion? Great, I'll pause there. It seems that a majority of people are saying that this is a chondroblastoma, and that's correct, that this is a chondroblastoma. When we look at this, we see our frontal radiograph, we see that there's kind of this focal area of lucency within the epiphysis of the proximal tibia. We know that this child is skeletally immature and that their physes are still open. And we can see, once again, that this lucent lesion is corresponding to a mass that's present within the epiphysis. We can see that on the sagittal T2 fat saturated sequences that there's a little bit of intermediate signal as well as some higher increased intensity, and that there is a lot of marrow edema-like signal and a lot of soft tissue inflammation surrounding it, extending into Hoffa's fat pad. And so for an epiphyseal lesion that is highly inflammatory, leading differential diagnosis in a kid is going to be chondroblastoma. And so chondroblastoma are benign chondroid-producing neoplasms that consist of chondroblasts. And they often occur, during the second or third decade of life. And so while they are often associated as a pediatric diagnosis, keep in mind that they can occur in your 20-something-year-olds. They are often occur at a single site, and this is usually in long bones, and their epiphyseal location is classic. And so when we think about the typical chondroblastoma imaging features, these are some kind of classic examples. We see, as I mentioned, that it's often involving epiphyses or apophyses and are very close in proximity to physes, especially if the child is skeletally immature. On radiography or CT, they're going to present as lytic lesions. They may have chondroid matrix, but they may not. So the lack of chondroid matrix should not dissuade you from thinking about a chondroblastoma. It's been described that they have a hypointense rim surrounding them. There's prominent surrounding marrow and soft tissue inflammation around these lesions. That's one of the defining kind of imaging features of chondroblastomas. And one of the more nuanced ones is that on T2 weighted imaging, a lot of these lesions have what we would describe as kind of intermediate signal. And this is related to kind of some immature chondroid matrix, as well as the chondroblasts themselves kind of create this more intermediate signal that is, above skeletal muscle, but not as high as something like fluid. And so when you think about your non-specific bone lesion that's T2 hyperintense and T1 hyperintense, if you see something that is intermediate, that would, support this diagnosis of chondroblastoma, especially if it's epiphyseal. And so the take-home point here, we're building our differential. We talked about osteoid osteitis, Langerhans cell histiocytomas, histiocytosis, and chondroblastoma should definitely be included on that list. Let's look at our next case. This is a 10-year-old male presenting with several months of right leg pain. What's the most likely diagnosis for this lesion? All right, so we'll pause here. We see that the majority of people are saying that this is an osteoblastoma, and I understand why. We have a lot of periosteal reaction. We see that we have this elongated lesion that's measuring up to 2 centimeters, but keeping in mind that it is very kind of tubular in shape. And once again, it's eccentrically located. You could probably call this kind of centered, if I were to put the center of it, probably in the subperiosteal region, and has this prominent surrounding periosteal no bone formation. This is actually an atypical form of osteoid osteoma that's has this elongated shape. And, we kind of call these elongated osteoid osteomas. And so these are all examples that, we've come across of these elongated osteoid osteomas. And so, the typical imaging features, we're going to have this very round, loosened tumor that has some internal mineralization. But for some reason, some of these osteoid osteomas can develop in these kind of stretched out patterns that have a very large craniocaudal or longitudinal dimension, which a much shorter kind of axial dimension. And so, some of these can measure up to even 4 centimeters. This is a very rare case, but we once again see this classic kind of internal mineralization, but keeping in mind that they kind of can have this stretched out appearance. Now, there have been multiple kind of case reports, and these have been described using different names. They've been called elliptical or multicentric, sometimes beaded, because it seems like they almost have multiple areas of nituses or kind of multiple tumors that are adjacent to each other. They've been called multicentric, once again, because of these multiple areas that are adjacent to each other, and also known as, tubular. All these are descriptive ways of just of the shape of these lesions, but all of these were osteoid osteomas. And so some of the research that I did was to look at these cases of elongated morphology, osteoid osteomas, and to understand, from our experience, we had kind of found that they were harder to treat. And so was this actually the truth? And so we kind of use this definition where craniocaudal length would be greater than 10 millimeters, because that's larger than your typical ablation, probe, but also that they would have this ratio of the craniocaudal dimension to the shortest transverse dimension of greater than 3, also known as an eccentricity index. And so we kind of define this as when they met this, meeting this definition of elongated morphology. And what we saw was that this was, 1, more common in younger children, and 2, associated with treatment failure in younger children. And so if we think about why that is, you have to think about how we are going to treat these. And so if we have this elongated lesion in a bone and we use our radiofrequency ablation probe, we're going to create this 1 centimeter sphere of necrosis. But this is when you may have to put in multiple needles to cover the full extent of the lesion. And that can be quite challenging technically, and as well as in children with kind of smaller bones. And so that may be a reason why these elongated morphology osteoid osteomas are associated with treatment failure in younger kids. And so the take-home point here is that, 1, there is this more, some of these osteoid osteomas can present with this elongated morphology, and they can predispose treatment failure in children. So when you're reporting these on your studies, it's really important to mention all three dimensions and to kind of highlight that this is an elongated lesion, or perhaps including in your impression the craniocaudal length, so that the person who will be ablating this may understand that you may have to use multiple probes. And the other thing is, if you are doing the ablations, to ensure that you have full coverage of the lesion with RFA. It's very important to look at your pre-procedural imaging, to get, if you're doing this by CT, to really get a good scan and to plan out to make sure that you're going to be covering the full extent of this, as it's most likely they're harder to treat because, or they're more likely to have treatment failure because of the fact that they're harder to treat. And finally, we're keeping in mind these atypical osteoid osteoma presentations. We talked about intra-articular ones, and we're thinking about elongated morphology. This is case 6. This is a 15-year-old male with several months of finger pain. What's the most likely diagnosis for this patient? We'll stop here. It seems that we're unanimous in thinking that this is an osteoid osteoma, and we're correct in this case. So as we look at our initial imaging on our radiography, we see that there is a lot of soft tissue swelling that's kind of centered around the middle finger or PIP joint. And we can also see that there's some periosteal new bone formation that's present kind of along, this is the ulnar aspect of the proximal phalanx here. And on our MRI, we can see that there is a lot of inflammation that's once again centered around this joint, and extending into the bone, and that there's bone marrow edema. And on this axial slice, we can see that there is actually some kind of a subtle signal abnormality that's present within the cortex. It was suggested that an osteoid osteoma could be the cause of this child's pain. A CT was obtained, and we can see that we once again see these kind of classic imaging features that really make us feel more confident in our diagnosis. We see that there's a radiolucent lesion that has internal mineralization. It's cortically based, and this was the cause of this child's pain. But things like juvenile idiopathic arthritis, septic arthritis, other kind of osteomyelitis are all things that were considered given the fact that we have this joint-centered inflammation. And so this is an osteoid osteoma. The take-home point here, as you may be starting to appreciate, is that osteoid osteomas can be really challenging to diagnose on MRI. And these typical features that we think about with our tumor with internal mineralization and periosteal bone formation can be really hard to pick out. And so always think about osteoid osteoma on your differential in a kid who has prominent marrow edema and subacute or chronic pain. I'm training myself to really ask myself that question anytime I see that history of, could there be an osteoid osteoma here, and to really go through the sequences very carefully to look for the tumor. And then finally, keep in mind that while osteoid osteomas most often occur in the lower extremity, in the bones like the tibia or the femur, they can occur in any bone in the body, in any location within bone and in any bone. And so these, when they occur kind of in the phalanges or in the feet and the hands, they can be sometimes challenging to diagnose as well. Or being aware of atypical O presentations and thinking about atypical locations or atypical bones is important. This is a 10-year-old male with several months of atraumatic knee pain. What's the most likely diagnosis in this patient? So we'll pause here, and we can see that a majority of people are saying that this is JIA. And some people are thinking that this is osteoid osteoma. When we look at this case, we can see that there is a lot of marrow edema-like signal and, not really quite marrow replacement, but at least some edema-like signal that's kind of present within the proximal tibia. It's present within the epiphysis, within the metaphysis. We have soft tissue edema-like signal that's extending kind of adjacent to this bone. And then we see that there is a focal lesion that is adjacent to the physis itself. That seems to be more hypointense than the surrounding edema. And so this is a periphyseal intramedullary osteoid osteoma. And so this is a little bit atypical because it's a bone that we would expect, but not necessarily the location within the bone that's most common for osteoid osteomas. And so in this particular case, this child had already had we can see here on this radiograph that we can that there's some sclerosis kind of in the region of the proximal tibial physis that corresponds to the site of the osteoid osteoma. And we can see that this child had a leg length discrepancy, a slight leg length discrepancy with the right leg longer than the left leg, which was affected. This child was treated, but unfortunately, they've had progressive leg length discrepancy. We can see here that after the radiofrequency ablation, we have the post-ablation changes, where we have increased lucency in this region, but we see that this proximal tibia appears dysmorphic, with kind of the lateral tibial plateau appearing a little bit more hypertrophic, the medial tibial plateau seeing a little bit more dysmorphic, and it has kind of resulted in a progressive leg length discrepancy. And so one of the complications with osteoid osteomas in children is when they're close to these physes, they can affect and cause growth disturbances. And so it's important to make timely diagnoses and to treat these to prevent the ongoing inflammation from further affecting the physis. And so to keep in mind that where osteoid osteomas can occur in bone, as we talked about, that the typical location is going to be cortically based. But when we think about and when we can describe the location of the tumor in the axial plane, we can kind of pinpoint where the center of the lesion is, and then we can characterize it by that. And so one is to call these kind of subperiosteal. If I were to put kind of the center of this lesion, it's not really directly within the cortex, it's adjacent to it. And these subperiosteal lesions tend to kind of result in a lot of surrounding periosteal bone formation. They can be intracortical, which is more classic when we think about osteoid osteomas. They can be endosteal, which is that the center is right adjacent to the cortex, but not within it. And then we can have intramedullary osteoid osteomas, which are rare, but can occur. And so this is important to keep in mind that not all osteoid osteomas need to be cortically based. This is another case that we had recently. This was a 17-year-old male who had 1.5 years of atraumatic shoulder pain. They were working up the neck, they were working up the brachial plexus. Finally, they ended up getting some imaging of the shoulder. We can see that there is a lot of marrow edema that's present within the humeral head. And on our T1 weighted imaging, we can actually see that there's a focal ovoid lesion that's present within the center of the medullary cavity in the metaphysis. And the radiologist, astutely noted that while this is not a classic cortically based location for an osteoid osteoma, that this could be an intramedullary osteoid osteoma. A CT was obtained to kind of confirm this. We can see the lucent tumor with some internal mineralization and some surrounding sclerosis. This was biopsied, and this came back as an intramedullary osteoid osteoma. So one other MRI sign to be aware of with some of these endosteal or intramedullary lesions is something called the dark rim sign, which is really kind of reflecting this rim of sclerosis that's surrounding this lesion. When you can kind of make out this almost ring of hypointense signal on T2 weighted imaging that outlines where the tumor is located. These are endosteal or intramedullary lesions, and this is something that can help support your diagnosis of an intramedullary or an endosteal osteoid osteoma. Is this perilesional hypointense signal or rim surrounding the tumor. So our take-home point here is to be aware of atypical O presentations. The intramedullary location is a possibility. This is our final case. This is a 12-year-old female that has several months of elbow pain. What's the most likely diagnosis in this case? Great, we'll end there. And we see that the majority of people are saying that this is osteochondritis dissecans or OCD. And that's absolutely correct, that this is an example of an OCD lesion. We can see here that there is a lesion that is present within the capitellum. It is right at the articular or subarticular surface. It is kind of has a T1 hypointense signal. It has a little bit of irregularity overlying kind of cortex and cartilage, and that there's some hyperintense signal that's kind of along the interface of this lesion with the underlying bone. And we can also see that there's a lot of marrow edema kind of surrounding this lesion itself. So there's the marrow edema, and of course there's our lesion here. This is a DES sequence, which is very useful for evaluating cartilage, and we can see that this is really centered kind of at this chondral, kind of subchondral location. So the capitellum, this is a classic look for an osteochondritis dissecans lesion. And so osteochondritis dissecans, or OCD, is a pathology that occurs in children and young adults and is really centered at this osteochondral junction. So really at the cartilage and at the bone right underneath the cartilage. And so the pathophysiology remains unknown. There's likely multiple factors that play into it. People think about overuse kind of as an inciting kind of factor, something that may contribute. There may be kind of local ischemia. There may be something predisposing related to bone strength or genetics. It's really unknown at this point. But the most common location that we see these is in the medial femoral condyle, but some other kind of classic locations that we see these are in the trochlea of the distal femur, as well as in the elbow and in places like the capitellum. Our moderator, Dr. Nguyen, has published some fantastic articles on osteochondritis dissecans. I'd highly recommend that you check them out because what are we looking for in radiologists is, one, to make the diagnosis, but two, to kind of ensure that the lesion is not unstable, where it could detach and result in one, pain, but also in kind of early osteoarthritis in these children. And so there are findings that we should really look for that can correspond with instability. From Dr. Nguyen's paper, kind of looking at these capitellar lesions, things that should really raise alarm bells for that there is imaging findings concerning for instability is when we see, a clear defect, something is missing. Perhaps we can even find it somewhere in the joint as an intra-articular body. If you see, full thickness cartilage lesions kind of overlying the site of the OCD, that's concerning for instability. When you see that the subchondral bone plate, which is this hypointense, signal, has been disrupted, that is an indirect sign and can be concerning. And then when you have fluid signal, not just hyperintense signal, but signal that's similar to fluid, that's actually at the interface between the progeny, which is kind of this potentially unstable fragment, and the parent, or the parent bone, is highly concerning for instability. And so these are some things to keep in mind with these OCD lesions. But to kind of round out our differential for inflammatory pediatric bone lesions, here's a case where we look at the fibula, we see some periosteal new bone formation, we see a lucent lesion. It's kind of ovoid, but kind of large in size and has some surrounding inflammation of both the bone and the soft tissues. This is an example of an osteoblastoma. When I showed that elongated osteoid osteoma case, some people were thinking about osteoblastoma because of the craniocaudal length. And classic teaching is that, we use 2 centimeters as a cutoff between osteoid osteomas and osteoblastomas. But, these are historical rules and may not be true all the time. One of the things about osteoblastomas is they not only are often 2 centimeters or more, but they are 2 centimeters in kind of multiple directions. They're not this elongated, stretched out shape like those elongated osteoid osteomas, but they're kind of more rounder. But they can have a very similar appearance to osteoid osteoma, both on imaging and on pathology. But one of the kind of classic features that may differentiate an osteoid osteoma from an osteoblastoma is if there's follow-up imaging, osteoblastomas tend to grow, while osteoid osteomas really tend to kind of stay at a similar size. Another inflammatory bone lesion here. This is quite ugly looking. We can see in the proximal tibia and the distal femur that we have this lesion that's present within the epiphysis as well as the metaphysis, and this is primary osseous lymphoma. But lymphoma in bone can result in surrounding edema-like signal as well. In children, these are commonly epiphyseal. They may be multifocal, where you see that in this case, we have a proximal tibial lesion, but also one in the distal femur here. And what's been described is that having this infarct-like appearance where you kind of have these serpiginous areas of non-enhancement within the lesion that kind of look like an infarct, and that can be something that can lead you to have that as the leading diagnosis on your differential. A final lesion I'll talk about is this one here. We can see that in the distal tibia that we have this kind of channel-like lucent lesion that's kind of centered at the metaphysis, but also tends to cross over the epiphysis. It's hyper-intense and kind of rounded. And this is an example of osteomyelitis or a Brody's abscess, an abscess within the bone. Classic kind of appearance for these Brody's abscesses to have these kind of elongated or channel-like morphologies. I showed you that atypical elongated osteoid osteoma, which is quite unusual, but generally tumors tend to grow kind of out in spherical patterns and not really in this elongated pattern. So sometimes when you see this elongated channel or morphology, you should think about something like an infection. They are often metaphyseal centered, as osteomyelitis and infection tends to occur in kids, but keep in mind that they can cross the physes, and they often have prominent surrounding inflammation from the infection. And so we wanted to kind of generate this differential diagnosis for pediatric bone lesions with prominent inflammation. Here we have it. We talked about osteoid osteomas, osteoblastomas, chondroblastoma, LCH, lymphoma, osteomyelitis, Brody's abscess, infection, and osteochondritis dissecans. This is not an extensive list, but if you recognize that prominent inflammation and think about these diagnoses, you're going to be heading in the right direction. So that's it for the lecture today. I just wanted to review the learning objectives to make sure that we were all on the same page and we kind of learned what we wanted to. And so we want to describe some of the typical features of an osteoid osteoma. I'd appreciate if people wouldn't mind typing in the chat just what are some of the typical features that come to mind that we talked about. See. Gee, I don't know if you're seeing any responses. They may not be able to be viewed, but that's okay. But we can see some of the images here, which are describing a lot of these kind of classic features. We talked about that we're looking for a small lucent lesion that may have internal mineralization. This is commonly known as a nidus. I don't love that term. It's often cortically based. It's more commonly extra-articular. There's prominent surrounding periosteal reaction, and there's prominent surrounding inflammation. We want to recognize some of the atypical presentations of osteoid osteoma. Some of the ones that we talked about were intra-articular locations, keeping in mind that those don't often have periosteal new bone formation. It can be quite tricky in just presenting with synovitis. Elongated morphology lesions, it's really important to give these dimensions to make sure that we're going to be treating these appropriately and using enough radiofrequency ablation probes. Atypical bones that can be involved, not just the tibia, the femur, their lower extremity, but also it can occur in any bone, including the hands and feet. And then intramedullary location, it does not have to be cortically based. And finally, we want to provide a differential diagnosis for an inflammatory lesion in a child. We talked about all of these lesions. I hope they're starting to stick in your mind, but we talked about osteoid osteomas, osteoblastomas, chondroblastomas, LCH, lymphoma, infection, and OCD. The final thing I want to leave you with is this message, is this key take home, is that if you see prominent bone marrow edema in a child or a young adult or an adolescent, and they're reporting non-acute pain without any trauma, I just want you to ask yourself, could there be an osteoid osteoma here? I want you to take that second look through these sequences, look for that small tumor, that small nidus that could be hiding in an atypical location or with an atypical presentation, because you can really help your patients a lot by making this diagnosis and suggesting it early. Maybe that's just suggesting the possibility and getting a follow-up CT. Thank you so much for your attention. I really appreciate the people who have attended and participated, and I'm happy to take any questions. Thanks.
Great, Eric. Thank you so much. That was an amazing talk and lots of excellent teaching points. If any of the audience have any questions, feel free to put that in the question answer or the chat box. And just to start off, I'm just wondering, I know we see these elongated osteosteoma, and it always makes me nervous calling it osteosteoma and not something else. Have you noticed, just curious, if there's a correlation between age and how long they are? I know the cases that you show, they're 2, 3 centimeters.
Yeah, some of those cases I was showing as we do in presentations are some of the longer ones and the more pretty ones. But I think, I often think about, elongated and being kind of greater than a centimeter because I'm thinking about the treatment implications for a radiofrequency ablation probe. In our analysis, we didn't kind of correlate the exact size, the cradiocaudal dimension with the specific age of the patient, but we did see that these lesions were more common, then, fitting that definition of greater than 10 millimeters in craniocaudal length and having that eccentricity index of greater than 3 were more common in children ages, 0 to 9, as opposed to kind of, adolescents being 10 to 19 years old. And so they do tend to kind of meet that criteria of being greater than 10 millimeters and having this slightly elongated shape, maybe not as dramatic as some of the examples I was showing, but I think in our cohort of children that were 0 to 9 years old, that consisted of almost 18% or 17% of cases kind of met those criteria. And so, it's something that I've taken away of really to always report the 3 dimensions and to really kind of highlight if one of those dimensions is going to be greater than a centimeter.
Very helpful. Um, and just curious, in your experience, are there typical sites that you would avoid ablating, that you would actually send to the surgeon for excision rather than ablation?
Yeah, I think it's really important to think about when you have a 1 centimeter sphere of coagulative necrosis, what could be in that sphere. And so I know that the spine is a classic location that we're very cautious about. There are a lot of nerves. It's a tough location to kind of get your probe. They can be close to vessels, small vessels. And so where I did my training at Mass General, a lot of these spine cases would either would go to surgery. But it's the treatment planning is really thinking about, how am I going to get my needle there and what is going to potentially be in the sphere of necrosis. And the spine is a classic area that we would tend to stay away from. Although there's fantastic publications about treating, spinal osteoid osteomas with ablation and having a high success rate, but it's technically challenging and can get a little tricky, but there are certainly spine lesions that are amenable to that.
Great. Well, thank you so much. There is a comment from Saeed in the chat saying, just wanted to thank you very, very much for this brilliant lecture. So
Thanks, I
it's
appreciate it.
excellent. So I think if we do not have any other questions, I wanted to thank everyone for attending. Thank you, Eric, again for the wonderful talk. And I want to remind the audience to please complete the survey, which is in the chat. Your feedback is greatly appreciated for these webinar as we plan for the next year. So thank you again, everyone, for attending. And this is a wrap for 2024-2025 academic year. So thank you.
Thanks, Dr. Wynn. Thanks everyone for attending.